Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former health commissioner here in Baltimore. Our goal is to bring evidence and experience to illuminate critical public health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith Rogers, producer of Public Health on Call. Today, I talk with vaccine experts Anna Durbin and Bill Moss about the global state of COVID-19 in terms of vaccine coverage, second-generation vaccines coming this fall, a new variant of concern, and what a worrying flu season in the Southern Hemisphere could mean for us this winter. Let's listen. Bill Moss and Anna Durbin, thank you so much for joining us again on Public Health on Call. We're here today to talk about the global state of COVID. What is happening? So, Anna, let's start with you. What's going on with COVID worldwide?
Hi, Lindsay, and thanks for having us today. Well, I think what we're seeing globally is continued cases of Omicron, although I think there is some encouraging news or numbers lately. We're seeing sort of flattening of new cases. I will say that the cases that are being reported are likely grossly undercounted due to home testing and such. But the good news is that we haven't seen the huge spike in hospitalizations that we saw earlier in January with the first Omicron surge. And deaths are fairly steady as well. So it does look as though even though we're seeing continued numbers of cases, we're not seeing hospitals overrun and we're not seeing increases in death. And I will say that's probably most likely due to the fact that most of the population has some immunity to COVID, either through vaccination or infection. But I do think we're going to continue to see cases, unfortunately, of COVID. It's not going away anytime soon. I think it is here to stay. So we just have to continue to be vigilant and keep our eyes on how things are going.
Bill, would you like to talk about the global state of vaccination rates, where we're going?
Yes, and I'll start off with what I think is very positive news. And it's important to step back and think about this. More than 12 billion doses administered. More than 5 billion people globally have received at least one dose of a COVID vaccine. That's an amazing accomplishment. We've never, as a global community, vaccinated as many people in such a short period of time, or even, against a single disease. So that's really a remarkable achievement. There are still gross inequities in vaccine coverage. I'll also point out we do need to account for the fact that a lot of people also have immunity from natural infection. And so, as Anna said, a reason for lower proportion of cases that are hospitalized or people dying is due to this combined immunity from infection with the virus as well as vaccination. But when we look at, say, for example, the continent of Africa, only about 25% of people have been fully vaccinated compared to, more than 80% in high-income countries around the world. So we still have these gross inequities in vaccine coverage that still need to be addressed. The other thing I'll say is there are now more than 120 different COVID vaccines, kind of in various stages of development with more than 50 in late stage development. That too is a remarkable accomplishment. You could, I think, justifiably ask the question, do we need that many vaccines? But it just shows the enormous scientific effort, technical effort, investment in these vaccines over the past couple of years.
And we're going to get more into vaccines a little bit later. But first, Anna, I want to ask you a question. So we are not seeing the hospitalizations. We're not seeing as many deaths. It sounds like the average case of COVID is milder than it was, maybe 2 years ago. We're also not seeing restrictions put in place as readily as they were before. What do you think about that?
Well, I think that's one of the reasons, again, that we saw sort of a surge or a lot of cases over the summer. I mean, just anecdotally, I can tell you I had more people let me know they got COVID in the past, I would say 4 to 6 weeks than probably the previous year and a half, which was really surprising. But I think a lot of that is because sort of people went back to pre-COVID lifestyles and interacting. And so I think to some extent that's encouraging. What I also tell people, though, is, I think it's important to remember that if you have symptoms, even if you don't know you have COVID, if you have, the sniffles, runny nose, cough, you might think it's allergies, get tested, wear a mask, use these precautions, not just for COVID, but we have flu season, coming up in a couple months for other respiratory diseases. I think that it's great that the severity of disease seems to be less. And I do think that that's because most people do have underlying immunity. But I think it's also important to note that we still see, particularly the most vulnerable, those over 65, those who have immunocompromising conditions or comorbid conditions are still at higher risk for hospitalization and even death. And I think, when we look at what the effects of the fourth dose of vaccine was, people always say to me, well, it doesn't look like it's preventing infection. Why should I get the fourth dose of vaccine? What I tell them is that, that helps people stay out of the hospital. It does help prevent infection for a short period of time, but it also prevents for a longer period of time those more severe complications. So, I think it's encouraging that there's less severe disease. I will say it doesn't mean COVID is over. It doesn't mean that we shouldn't protect ourselves and protect others. I think we can breathe a sigh of relief and say, yes, we can go back to somewhat normal activities, but we still need to take common sense precautions to prevent transmission and to prevent ourselves from being infected.
There's one population in the U.S. that has been a little bit discouraging in terms of vaccine rates. So, Bill, do you want to talk about pediatric vaccines?
Yes, you're referring, Lindsay, to the under 5 population in the United States. And the latest CDC data suggests that, perhaps about 3% or so of under 5s have been vaccinated. So this is very low. It's not completely surprising to me that the vaccine coverage is so low in that age group, although I certainly would have liked to have seen it higher. We have seen lower vaccine coverage in the 5 to 11-year-old age group, although not that low. And I think, in the youngest age group, obviously, those vaccines, they became eligible for vaccination much later in the course of the pandemic. Younger children are at lower risk of severe disease. The risk is not zero, and younger children still can get severe COVID, and some die, or some get what's called the multi-system inflammatory syndrome in children. So these longer-term complications. So it's not a disease without risk in the younger age group. It is of some concern, I'll say, that the vaccine coverage has been that low in children younger than 5.
So let's talk a little bit about the fact that we have, again, a new variant of concern. This is BA.4/6, I believe, and it's starting to tick up around the same time. We're also seeing this really devastating flu season in the Southern Hemisphere. So can we talk a little bit about sort of the convergence of these two things, or what we know so far about the timing of these?
I think what we've seen the past 2 years is relatively mild flu seasons. And I think that has a lot to do with what I was talking about earlier, common sense precautions against transmission of COVID work to prevent transmission of influenza. And unfortunately, what that means is that we have less population immunity to influenza because it hasn't been circulating. So we've been expecting, we actually last year were concerned that we might have a big excess number of influenza cases in the fall. That did not happen, but it does appear to be happening, in the Southern Hemisphere, in New Zealand and Australia. And I think it is concerning. What does that mean for the US? Well, it means if, we also may have a surge of influenza. We do have, seasonal influenza vaccines. I will say uptake of those vaccines has not been great historically. I think probably this fall it's going to be very important, particularly for those populations who are most vulnerable to severe influenza, which are the elderly and the very young, to get vaccinated when those influenza vaccines are available. But I will say the public health communities are aware of this. They are sort of on heightened alert that this may happen. And I think right now it's just sort of a wait and see what's going to happen in terms of the numbers of cases of influenza. We'll be able to vaccinate against both influenza and the newer variants of COVID in the fall, whether we'll be able to give 2 vaccines at the same time or they'll have to be spaced because one might not be ready when the other one is. We have to wait and see. But I encourage everyone, again, vaccination against both influenza and COVID is important in the reduction of severe disease, hospitalization, and death.
And so, Bill, can you talk a little bit about what we know about this new variant?
Yeah, so I'll first say, Lindsay, that we should expect and will see, continued new variants of SARS-CoV-2. There's no doubt about that. This virus is going to continue to mutate, as particularly when it transmits at such high levels. The big question is really, in my mind, whether it can escape pre-existing immunity, because if it can do that, then the pool of susceptible people in the population who can get infected and transmit the virus is much, much greater. If it can't escape pre-existing immunity, or there's that, what I'll call partial immunity, and that's what we're seeing now with immune protection against severe disease, except in the most vulnerable, as Anna said, that's going to protect us from hospitalizations and deaths, and that's really important. The point is, can these new variants escape immunity? This virus does not have an infinite capacity to escape immunity. At some point, it's going to be limited in its ability to do that, because it needs to it needs to bind to our cellular receptors and get into our cell and be transmitted. The 4.6 variant, this newer Omicron variant, this has been seen in a number of countries around the world. We're seeing it in some states now. BA.5 is still the dominant variant in the United States. And I don't think we know yet whether this variant, the BA.4.6, will really be able to escape immunity. I suspect that it's not going to be able to escape immunity, certainly from people who've had BA.5 before. There are a few mutations that distinguish it. But we'll have to see. It's still quite early, and we're still learning more about the BA.4.6 variant.
It's really important to keep things in perspective. So as Bill was saying, these variants escape immunity. I think it's important to realize the reason they're able to infect is because we don't have antibody titers high enough where the virus comes in. And that happens with all respiratory viruses, that, eventually your antibody titers decline. What we are still seeing, as Bill alluded to, is immunity that's protective against severe disease and death. These viruses are able to infect locally in the mucosa because our bodies can't keep antibody titers high enough. It's not the way our immune system is designed. But to Bill's point, I think what we're going to see is it can only mutate so much before we have enough underlying immunity to at least prevent symptomatic infection. And I think, hopefully we'll start seeing that in the future.
The intranasal vaccines, the mucosal vaccines, may be able to provide some of that frontline infection protection that the high titers of neutralizing antibodies, as Anna said, can't, just because they're not sustained.
What do we know about those vaccines? When will they be available? Will they be available widespread?
There are a number of candidate vaccines, intranasal vaccines. Some of them are very far along and look quite promising. I don't know that they'll be available kind of this year, but I'm hopeful in the future. And I think they'll be very good booster doses going forward.
And that is a key point that Bill just said, booster doses. I think the intranasal vaccines, that's really where they thrive and where they're going to provide great benefit. I don't know that they would be as effective as a priming series, just because they don't induce what we call systemic, the immunity throughout the body, the way the intramuscular vaccines do. But as booster doses, they're excellent. I mean, it's a wonderful strategy because then you can block the virus at the point of entry. To Bill's point, I don't think they'll be ready this year. They have to do more extensive testing than these second generation mRNA vaccines or inactivated vaccines do, just because we don't have experience with them.
So Anna, let's stay with you. That's a great segue into talking about these second generation vaccines. What can we expect? When are they coming?
So they are coming in the fall. I don't think they'll be here in September, unfortunately. I think it'll be later, October, November, just because there is a little bit of testing to do just to make sure that they induce the immune response or antibody response in particular that we're looking for. They will be a combination vaccine of the original sequence of mRNA, the original vaccine, plus an Omicron variant specific vaccine. So it's bivalent. So it will provide much better protection. We're hoping that they're going to be at least BA5 specific. I think it's important to note that it takes time for these companies to get the sequence, make the vaccine, and do the testing. So I think the best we can expect is a BA5 specific bivalent vaccine. I don't think if 4.6 becomes an important variant, I don't think we'll have a vaccine ready, but I'm very confident that they're so similar that a BA5 vaccine would induce very good immune responses against any related Omicron variant. So, the ones that are coming first will be the mRNA bivalent vaccines. I'm sure the other companies will be following, but it will take a little bit longer for that.
Bill, do you want to talk a little bit about what we know, like around vaccine fatigue? By the time that these vaccines come out, and we've already talked about this potentially horrendous flu season that may be facing us, what are we up against when it comes to getting people boosted and maybe even vaccinated for the flu?
Yeah, I think we have a big challenge ahead of us. If we look even just at the proportion of people in the United States who've received, the first 2 doses, the primary series, the proportion who've received at least a first booster dose, it's not high. It's in the order, 40 to 50% across different age groups. And I think that does reflect some fatigue, people feeling that they've moved on from the pandemic, as we were saying earlier, in terms of relaxing all the restrictions that we had earlier. It's very understandable, but people are who have received 2-3 doses of a vaccine are experiencing infections and hearing their friends getting infected. So I think all of that combines to a real challenge in, when these second generation vaccines become available, in getting people to accept them and to be vaccinated. And, just to come back to Anna's point earlier, I'm quite concerned about the influenza season coming forward. And I hope that this kind of reluctance or vaccine fatigue with COVID doesn't translate into very low coverage with influenza vaccines, because I am concerned that we could potentially see a lot of morbidity and mortality from influenza in this coming season.
And so this is a question really for either of you. Zooming out a little bit. So the US is prepping to bring these bivalent vaccines to market. Meanwhile, as we've already talked about, there are other parts of the world that are struggling to even get initial doses out. What's the big picture here with these second generation vaccines? Will they need to become very quickly more widespread available? Are we going to continue using the original vaccines?
I think in much of the world, there's still the vaccines that will be available will be against the original Wuhan strain. It's going to be some time before any second generation vaccine, such as a bivalent vaccine, becomes available more widely. And to be honest, by that time, we may have moved on from Omicron and there may be quite a different variant. So it's very hard to foresee that there's going to be a huge global market, say a year from now, for an Omicron specific variant. We may be in a very different situation. I do think that, this combination of immunity from natural infection and immunity from vaccination, and we see this in seroprevalence surveys that are done around the world, where very high proportions of populations have some antibodies. They're not going to prevent infection necessarily, but it shows that people have some pre-existing immunity, that's going to diminish morbidity and mortality, as we've said. And we'll continue to see this virus mutate, change. It's going to continue to be with us. We're not going to have an end to this, but hopefully it will become a milder disease as a consequence of the pre-existing immunity.
So Anna, any final thoughts?
No, I just could not agree with Bill more. And I think that that's really something we have to manage people's expectations, I think. And I'm not sure we've done a great job of doing that in the past. We may see third generation vaccines, or we'll see different vaccines for different strains as the virus continues to evolve. Who knows? It may become sort of like influenza with different variant specific vaccines each year. We don't know that yet. And I think, patience, and we have to continue to look at the data and act on, what the data tell us.
So we'll certainly check back in with both of you at some point in the next year to take a look at that viral stability and see where we are. But thank you so much for joining us today. We appreciate your time.
Oh, it was fun. Thank you.
Thank you, Lindsay.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinell, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Holes Fernandez and Amber Bryan Singletary. Thank you for listening.